In patients with acute pancreatitis, endoscopic interventions now play an important role in the management of pancreatic fluid collections. Radiologists interpreting CT studies in affected patients need to understand current endoscopic techniques and how imaging findings can help guide appropriate treatment. In this paper from the Oregon Health and Science University and colleagues in Portland, Maine, and Salt Lake City, Utah, the authors begin by providing a review of the 2012 revision of the Atlanta Classification System of Acute Pancreatitis, the topic of a May 2016 RadioGraphics article authored by the same OHSU group. In 5 to 10% of patients with acute pancreatitis, necrotizing pancreatitis that is associated with a poorer prognosis than the much more common interstitial edematous pancreatitis is seen on CT as regions of non-enhancing parenchyma and/or necrotic collections. The spectrum of pancreatic and peripancreatic fluid collections include acute peripancreatic fluid collection, pseudocyst, acute necrotic collection, and walled-off necrosis. The characteristic timing of development of these collections relative to the onset of pain and the typical location and imaging features seen are listed in Table 1. Endoscopic interventions have largely supplanted surgical debridement for the management of necrotizing pancreatitis due to improvements in endoscopic techniques and instrumentation and the high complication and mortality rates associated with surgery. In fact, endoscopic transmural drainage and endoscopic transmural necrosectomy are now considered first-line and often definitive treatments for walled-off necrosis when treatment is deemed necessary. An important principle in the modern management of pancreatic fluid collections is the step-up approach, in which minimally invasive techniques are used initially, with definitive necrosectomy either delayed or avoided altogether if possible. The authors illustrate the use of cystogastrostomy and cystoduodenostomy for fluid collection management. Radiologists need to accurately describe fluid collection size, location, characteristics, and the presence of intervening vessels to help the endoscopist plan for the procedure and determine the type of stent to be used for successful drainage. Table 2 in the paper lists those imaging features in acute pancreatitis that are important for the radiologist to include in his or her radiology report. Similarly, endoscopic transmural necrosectomy using a step-up approach is illustrated. In selected cases, a multifaceted approach including percutaneous drainage and video-assisted retroperitoneal debridement may be employed in conjunction with endoscopic techniques. Pancreatic duct interventions, including stent placement, duct stricture dilatation, and duct stone extraction, may be used to relieve ductal obstruction and facilitate gland drainage. Disconnected duct syndrome, which complicates up to 1/3 of patients with necrotizing pancreatitis, has characteristic imaging features at CT and is important to recognize. After a brief discussion of biliary interventions in patients with suspected gallstone pancreatitis, the paper reviews the complications of endoscopic interventions in the treatment of pancreatic fluid collections, with imaging examples of bleeding, infection, perforation, and stent migration, and the so-called buried-stent syndrome. The paper can be found at the following link.